Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. The advent of biologic therapies has fundamentally revolutionized the management of numerous complex diseases. However, their protein-based nature introduces a unique and critical regulatory and clinical challenge: immunogenicity, defined as the propensity of a therapeutic protein product to generate immune responses to itself. The focus in therapeutic medicine is managing unwanted immunogenicity, which directly impacts the safety and efficacy profile of a biologic agent. The clinical consequences of immunogenicity exist on a wide spectrum, but the most direct and predictable effect is the alteration of pharmacokinetics, resulting in accelerated drug clearance and decreased patient exposure. This pharmacokinetic effect often leads to a secondary loss of therapeutic efficacy. The immune response is mediated by anti-drug antibodies, which are classified as non-neutralizing or neutralizing antibodies. Neutralizing antibodies are often more strongly correlated with a loss of clinical efficacy. Effective management requires a comprehensive risk assessment, recognizing that the likelihood of a clinically significant immune response is complex and multifactorial. Key factors include properties intrinsic to the drug, such as aggregation and sequence foreignness, patient characteristics such as genetic predisposition, notably the human leukocyte antigen genotype, and treatment variables including dose, dosing interval, and the use of concomitant immunosuppressants. The clinical pharmacist is uniquely positioned to play a pivotal role in this domain. This responsibility includes implementing proactive risk mitigation strategies, guiding the rational use of therapeutic drug monitoring and the tiered approach to immunogenicity testing, and championing a structured, algorithmic approach to interpret laboratory results, including anti-drug antibody status, neutralizing antibody activity, and drug concentration to guide evidence-based therapeutic decisions. This comprehensive guide provides the foundational knowledge necessary for the clinical pharmacist to navigate the challenges associated with immunogenicity and ensure the long-term viability of biologic therapies. The following learning objectives are designed to help understand biologic immunogenicity, emphasizing the important role of the clinical pharmacist in assessing risks and managing therapies. These objectives are aligned with foundational pharmacy education. First, students should define immunogenicity in the context of therapeutic proteins and describe how it can alter drug pharmacokinetics, leading to reduced patient exposure and potential loss of treatment efficacy. Next, it is important to distinguish between neutralizing antibodies and non-neutralizing anti-drug antibodies. Neutralizing antibodies diminish the functional quality of the drug, affecting its pharmacodynamic effect, while non-neutralizing anti-drug antibodies reduce the drug quantity, influencing its pharmacokinetic profile. Students should also explain the primary mechanism behind the generation of robust, high-affinity anti-drug antibody responses, which involves the T-cell-dependent pathway. This process requires presentation of T-cell epitopes through major histocompatibility complex class II molecules. It is essential to identify the key factors related to the product, such as protein aggregation, glycosylation patterns, and the foreignness of the sequence, alongside patient-related factors, including specific human leukocyte antigen genotypes, like human leukocyte antigen, DQA1*05, which may contribute to the risk of immunogenicity. Furthermore, students should outline the regulatory recommended four-tiered approach to testing immunogenicity, which includes screening, confirmation, titration, and neutralizing antibody assays. Each tier serves a specific purpose in the clinical investigation of immunogenic responses. Proactive use of therapeutic drug monitoring is also important as a strategy to reduce the risk of immunogenicity by maintaining drug concentrations within a tolerogenic window. The structured algorithm for managing secondary loss of response involves integrating data on trough drug concentrations and antibody status to determine whether the failure results from pharmacodynamic issues, non-immunogenic pharmacokinetic changes, or immunogenicity-driven pharmacokinetic alterations. Students should recommend appropriate risk mitigation strategies for patients at high risk. These may include the concurrent use of immunosuppressants, such as methotrexate, or selecting an alternative biologic therapy. It is also important to differentiate between the two main bioanalytical platforms used to measure antibodies, namely enzyme-linked immunosorbent assay and electrochemiluminescence. The latter offers advantages such as better drug tolerance. Finally, students should understand the steps and underlying mechanisms involved in rapid drug desensitization. For managing severe, immediate hypersensitivity reactions to essential biologic therapies, a common method includes a 12-step protocol using 3 different bags to gradually desensitize the patient. The rise of biologic therapies has significantly transformed the treatment of many complex diseases. These therapies are protein-based, which presents a unique challenge known as immunogenicity. Immunogenicity is defined from a regulatory standpoint as the tendency of a therapeutic protein product to provoke immune responses against itself or related proteins. It can also lead to adverse clinical events that are immunologically related. This phenomenon is a crucial factor in drug development because it directly affects the safety and effectiveness of biologic treatments. While some immune responses may be beneficial, such as in the case of vaccines where immune activation is desired, the goal for therapeutic proteins is to prevent and manage immune responses that are undesirable. Unwanted immunogenicity can compromise the therapeutic goals of these biologic medicines. The clinical consequences of an immune response to a biological therapy vary widely, ranging from no noticeable effect to severe, life-threatening complications. The most common and concerning outcome is a reduction or complete loss of the treatment's effectiveness, often referred to as secondary loss of response. For instance, in patients treated with adalimumab, a widely used anti-tumor necrosis factor monoclonal antibody, the development of high levels of antibodies against the drug is directly linked to faster clearance of the medication and a shorter duration of its anti-inflammatory action. Essentially, the formation of these anti-drug antibodies significantly affects the pharmacokinetics, the way the drug is absorbed, distributed, metabolized, and excreted. When an immune response occurs, it almost always results in increased drug clearance and decreased exposure to the therapy for the patient. This alteration in pharmacokinetics is the most predictable and direct consequence of immunogenicity. The subsequent loss of treatment efficacy is often a downstream effect of this primary change in pharmacokinetics. Beyond their efficacy, the immunogenicity of therapeutic agents also presents significant safety risks. These risks can manifest as immediate adverse events, such as severe allergic reactions and cytokine release syndrome. Additionally, delayed symptoms like rash, joint pain, and facial swelling have been observed with certain medications such as infliximab. In rare cases, immunogenicity can lead to serious and potentially devastating outcomes. For example, the development of autoantibodies against recombinant erythropoietin has resulted in life-threatening conditions such as pure red cell aplasia. This condition occurs because these autoantibodies neutralize not only the therapeutic protein, but also the patient's own endogenous protein. The potential for cross-reactivity, where autoantibodies against a therapy also target the body's natural proteins that have essential physiological functions, is a major safety concern. Such cross-reactivity can cause long-lasting, autoimmune-like deficiencies that severely affect patient health. Understanding the variability of immunogenicity among different biologic drugs is essential for pharmacists. The incidence and clinical impact of immunogenic responses can differ significantly from one biologic to another. For example, The formation of anti-drug antibodies is almost non-existent with canakinumab, a biologic used in inflammatory diseases. In contrast, the rate of antibody development can exceed 40% in patients treated with infliximab. It is important to recognize that the presence of anti-drug antibodies does not necessarily mean the treatment will fail. For drugs such as rituximab, which is used in certain autoimmune conditions, the development of antibodies has been observed in up to 11% of patients, but generally does not affect the safety or effectiveness of the treatment. This variability highlights that a positive test for antibodies should not be viewed as a final endpoint, but rather as the beginning of a clinical investigation. The significance of these antibodies depends on their specific characteristics, including their concentration, whether they persist over time, and their functional ability, as well as their measurable impact on how the drug is processed in the body and on the patient's clinical response. The formation of antibodies against drugs is a key feature of the immune system's response to biologic therapies and serves as an important marker for immunogenicity. These antibodies are not all the same. Instead, they are a diverse group of immune proteins that can be generally divided into two main types: those that bind to the drug without preventing its action, and those that neutralize the drug's effects. Understanding the difference between these two types is crucial for accurately interpreting immunogenicity data and making informed clinical decisions. Non-neutralizing anti-drug antibodies, also called binding anti-drug antibodies, are antibodies that attach to regions of the biologic medication that are not directly involved in its pharmacological activity. For example, these antibodies may bind to the fragment crystallizable region of a monoclonal antibody. Although these antibodies do not directly inhibit the drug's function, their clinical impact mainly involves changes in pharmacokinetics. When they bind to the biologic, they form immune complexes. These complexes are recognized by the reticuloendothelial system, which clears them rapidly from circulation. The reticuloendothelial system includes phagocytic cells in the spleen and liver. This accelerated clearance results in lower concentrations of the drug in the bloodstream during trough periods and overall reduced exposure to the medication. Consequently, this can lead to a loss of therapeutic effect because the drug levels become insufficient for effective treatment. Neutralizing antibodies, NAbs, in contrast, represent a functionally distinct and often more clinically concerning subset of anti-drug antibodies. These antibodies directly inhibit the biological activity of the therapeutic agent. They achieve this by binding to or near the drug's active site. For monoclonal antibodies, this is often the antigen binding fragment, Fab, or the specific complementarity determining regions, CDRs, thereby physically blocking the drug from engaging with its intended target. In some cases, NAbs may bind to other sites on the molecule, inducing a conformational change that renders the drug inactive. The presence of NAbs is frequently more strongly correlated with a loss of clinical efficacy than the presence of non-neutralizing anti-drug antibodies alone. Consequently, specific NAb assays are a crucial component of a comprehensive immunogenicity assessment and are typically performed as a follow-up test on samples that have already been confirmed positive for anti-drug antibodies. This dual classification reveals that immunogenicity can compromise a drug's efficacy through two distinct but potentially synergistic mechanisms. Non-neutralizing anti-drug antibodies reduce the quantity of available drug through accelerated clearance, a pharmacokinetic effect, while neutralizing anti-drug antibodies diminish the functional quality of the drug that remains in circulation, a pharmacodynamic effect. A patient may therefore experience treatment failure because there is not enough drug present, because the drug that is present does not work, or, most commonly, a combination of both. This distinction is vital when interpreting therapeutic drug monitoring, TDM, results. A low drug level in the presence of only non-neutralizing anti-drug antibodies might be overcome by increasing the dose. However, if significant NAb activity is also present, dose escalation may be futile, as the additional drug will also be functionally inactivated. This highlights the necessity of having data on both drug concentration and NAb status for optimal clinical decision-making. The process of generating a robust and persistent immune response against a protein therapeutic agent is a complex biological event that is managed by the body's adaptive immune system. In most cases involving biological drugs, this immune response is dependent on T cells, specifically requiring the active participation of CD4 positive T helper cells for the process to continue. Gaining an understanding of this mechanism is essential for comprehending the molecular basis of immunogenicity. It also helps to explain the reasoning behind current strategies aimed at reducing immune responses to biologic therapies. The T-cell-dependent pathway is the primary mechanism responsible for immunogenicity to therapeutic proteins. The process begins when the biologic drug is taken up by professional antigen-presenting cells, such as dendritic cells. Inside these cells, the large protein molecule is broken down into smaller peptide fragments through proteolytic degradation. These peptides, known as T-cell epitopes, are then loaded onto major histocompatibility complex class II molecules and presented on the surface of the antigen-presenting cells. Naive CD4 positive T helper cells circulate continuously and monitor these presenting cells. If a T cell has a receptor that specifically recognizes the peptide MHC complex, it becomes activated. Activation leads to the proliferation and differentiation of these T helper cells. Once activated, these T helper cells provide essential co-stimulatory signals to B cells that have independently recognized the intact biologic drug through their B cell receptors. This interaction, mediated by molecules such as CD40 and CD40L, is a critical step that triggers a comprehensive B cell response. This response involves several processes that enhance the immune system's ability to fight pathogens. One of these processes is somatic hypermutation, which introduces mutations into the antibody genes, leading to the production of antibodies with stronger binding affinity to their specific antigens. This process is complemented by affinity maturation, which selects for the most effective antibodies, ensuring that the immune response becomes more targeted and efficient over time. Another important process is class switching, where the immune system changes the type of antibody it produces. Initially, the body produces immunoglobulin M antibodies, but it can switch to produce high-affinity immunoglobulin G antibodies, which are more effective in neutralizing pathogens. The body can also produce other classes of antibodies, such as immunoglobulin E, which play a role in mediating allergic reactions. Ultimately, these processes contribute to the generation of long-lived plasma cells and memory B cells. These cells are essential for providing a durable immune response, allowing the body to quickly recognize and respond to pathogens it has previously encountered. A secondary and less common mechanism is the T-cell-independent pathway. This pathway is usually activated by non-protein antigens that have highly repetitive structures, such as polysaccharides. It can also become relevant for biologic drugs if they form large and ordered aggregates. These aggregates can create a multivalent structure that is capable of extensively cross-linking B-cell receptors on the surface of B cells. Such strong signaling through the B-cell receptor can sometimes provide enough stimulation to activate B cells without the help of T cells. The immune response generated by this pathway is typically different from the T-cell-dependent response. It is generally weaker and results in the production of low-affinity, short-lived immunoglobulin M antibodies. This response involves little to no process of affinity maturation, class switching to immunoglobulin G, or formation of immunological memory. The dominance of the T-cell-dependent pathway reveals a fundamental principle. The primary cause of immunogenicity in most biologic drugs is the presence of specific peptide sequences, called T-cell epitopes, within the drug's primary structure. These epitopes are capable of binding to a patient's particular major histocompatibility complex class II molecules. The entire process of producing high-affinity, long-lasting anti-drug antibodies depends on the initial activation of T cells. If a therapeutic protein does not contain peptide sequences that can be effectively presented by a patient's major histocompatibility complex molecules, a strong T-cell-mediated immune response cannot be initiated. This principle provides a molecular understanding of genetic risk factors, such as specific human leukocyte antigen alleles, which encode major histocompatibility complex proteins. It also forms the scientific foundation for modern strategies aimed at reducing immunogenicity. These strategies utilize computational algorithms and advanced protein engineering techniques to predict and eliminate potential T-cell epitopes from the sequence of a biologic. The goal is to make the molecule less visible to the immune system before it is administered to a patient. The likelihood of a patient developing a clinically significant immune response to a biologic medication does not depend on a single factor. Instead, it results from a complex interaction of multiple variables. Therefore, a thorough risk assessment must include a structured evaluation of factors related to the drug itself, the characteristics of the patient, and the specifics of the treatment regimen. Regarding the properties of the biologic drug, the intrinsic immunogenicity of the molecule is a key consideration. These properties are related to the origin of the molecule, its structural features, and the quality of the final drug product. Understanding these factors is essential for assessing the potential for an immune response. The history of monoclonal antibody (mAb) development is a direct reflection of the ongoing effort to minimize immunogenicity by progressively increasing the humanness of the therapeutic protein. This evolution can be categorized into 4 distinct generations, identifiable by the World Health Organization's International Non-Proprietary Name, INN, suffix. Murine immunoglobulin antibodies, also known as the first generation of therapeutic monoclonal antibodies, were entirely derived from mouse proteins through hybridoma technology. An exemplary case is muromonab, CD3, which was the first monoclonal antibody approved by the United States Food and Drug Administration in 1986 for the purpose of preventing transplant rejection. Since these antibodies consisted of 100% mouse protein, the human immune system often recognized them as foreign substances. This recognition triggered a strong human anti-mouse antibody response, which led to rapid clearance of the drug from the body, diminished therapeutic effectiveness, and a heightened risk of allergic reactions. Chimeric antibodies, which are approximately 70% human, were developed to reduce the risk of human anti-mouse antibody responses. This approach involves fusing the variable regions of a mouse antibody, responsible for determining antigen specificity, with the constant regions of a human antibody. This composition significantly diminishes the immunogenicity compared to entirely mouse-derived antibodies. Examples of chimeric antibodies include infliximab, an agent that targets tumor necrosis factor alpha for inflammatory diseases, and rituximab, which is used in oncology and autoimmune conditions. Despite these modifications, the remaining mouse-derived variable regions can still be recognized as foreign by the immune system, potentially provoking an anti-drug antibody response. Humanized monoclonal antibodies are a significant advancement in therapeutic development. This process involves reducing the mouse protein content to only the essential regions responsible for binding to antigens, known as the complementarity determining regions. These regions are grafted onto a framework derived from a human antibody, resulting in a therapeutic molecule that is approximately 95% human. Such modifications help to lower the risk of immune reactions against the treatment. Examples of humanized antibodies include trastuzumab, used for treating breast cancer that overexpresses the human epidermal growth factor receptor 2, and alemtuzumab, which targets the CD52 antigen. Despite their high similarity to natural human antibodies, humanized antibodies can still provoke immune responses. This is because the grafted mouse regions may contain unique sequences called idiotopes, which the immune system may recognize as foreign. The development of fully human antibodies aims to minimize immune reactions caused by sequence differences. These antibodies are created using technologies such as genetically engineered mice that carry human immunoglobulin genes or through laboratory techniques like phage display. Fully human antibodies are composed entirely of human sequences, which theoretically makes them more compatible with the human immune system. Examples of such antibodies include adalimumab, which is used to inhibit tumor necrosis factor alpha, and the checkpoint inhibitors pembrolizumab and nivolumab, both of which are used in cancer treatment. However, even fully human antibodies can trigger immune responses. This occurs because the engineered complementarity determining regions, designed to bind specific targets with high affinity, can form novel structures known as idiotopes. These structures are not found in natural human antibodies. The immune system may not recognize these idiotopes as part of the human antibody repertoire, leading to the development of anti-drug antibodies. As a result, studies have shown that fully human antibodies and humanized antibodies can exhibit similar levels of immunogenicity. The structural integrity of the protein and its post-translational modifications are essential factors to consider. Protein aggregates, which are clumps of misfolded or associated protein molecules, serve as a particularly potent danger signal to the immune system. These aggregates can form during various stages such as manufacturing, shipping, storage, or even after administration through subcutaneous injection. Once formed, they are efficiently taken up by antigen-presenting cells, which can trigger strong immune responses through both direct and indirect pathways. Post-translational modifications, such as glycosylation patterns, the attachment of sugar molecules to the protein, also play a crucial role. The cellular machinery used to produce biologic products can introduce modifications that differ from those found on naturally occurring human proteins. For instance, non-human glycan structures can be highly immunogenic. These variations may lead to the formation of new structures called neoepitopes, which the immune system recognizes as foreign, potentially provoking an undesirable immune response. Impurities in the formulation of a drug can significantly influence its potential to provoke an immune response. Process-related impurities such as residual proteins from the host cells, DNA, or lipids originating from the manufacturing cell line can act as natural adjuvants. These substances can amplify the immune response against the therapeutic protein itself. The formulation of the drug, including the choice of excipients and stabilizers, is crucial in maintaining the stability of the protein. Proper formulation helps prevent the formation of protein aggregates during storage, which can otherwise increase immunogenicity. This highlights that immunogenicity is not solely determined by the amino acid sequence of a protein, but is also profoundly affected by the entire manufacturing process, purification, formulation, and handling procedures. Understanding this connection between product quality and immunogenicity is essential during the development of biosimilar products. Demonstrating that these products are highly similar in their quality attributes is critical to ensuring they have a comparable immunogenicity profile to that of the original reference product. For pharmacists, this emphasizes the importance of proper storage and handling of these products to preserve their integrity. Adequate storage and careful handling can minimize the formation of protein aggregates and thereby reduce the risk of immune reactions induced by the product. While the product itself provides an antigenic stimulus, whether an immune response occurs and its nature depend ultimately on the patient's individual characteristics. One of the most important factors is genetic predisposition, especially the patient's human leukocyte antigen genotype. These genes encode the major histocompatibility complex molecules responsible for presenting peptide fragments to T cells. Since different human leukocyte antigen variants bind to different peptide sequences, the specific type present in a patient determines which parts of a therapeutic protein can be shown to their T cells. This process forms the core of the immune response against the drug. This genetic connection is supported by clinical evidence. A well-documented example involves the human leukocyte antigen, DQA1*05 allele, which significantly predicts an increased risk of developing antibodies against certain anti-inflammatory drugs used in treating inflammatory bowel disease. Such drugs include infliximab and adalimumab. This knowledge points toward a future where genetic screening could help identify patients at higher risk of immune reactions before starting treatment. By doing so, healthcare providers could choose alternative therapies or require additional immunomodulating treatment for these high-risk individuals. These strategies would personalize therapy and potentially reduce treatment failures, improving patient outcomes. The patient's age can also influence immune responsiveness. The immune system is not static throughout life. Children, particularly those receiving replacement therapies for genetic disorders where the therapeutic protein is a true neoantigen, may be at a higher risk for developing antibodies. Some evidence suggests that very young children, 2 to 5 years, may have a higher prevalence of anti-drug antibodies than older children. Conversely, while one might expect the elderly to have a diminished response due to immunosenescence, some studies have paradoxically observed a higher risk of immunogenicity to infliximab in older patients, which may contribute to the lower efficacy sometimes seen in this population. The patient's underlying disease, comorbidities, and overall immune status are also critical determinants. The nature of the disease itself can modulate risk. Patients with highly active autoimmune conditions like rheumatoid arthritis may have a pre-activated immune system that is more prone to mounting a response against a therapeutic protein. The patient's general immune competence is also a factor, as an immunosuppressed individual is less likely to generate a robust ADA response. Finally, the patient's prior exposure to other biologics can prime their immune system for future responses. Previous treatment with a related protein can establish immunological memory, leading to a faster and more potent ADA response upon exposure to a second, similar biologic. This is particularly relevant when switching between therapies within the same class, as patients who developed anti-drug antibodies to a first anti-TNF agent are at a higher risk of developing them against a second one. In some cases, individuals may even have pre-existing antibodies from environmental exposures that cross-react with a biologic, leading to rapid or first-infusion reactions. The most well-documented example of this phenomenon involves patients switching between different anti-tumor necrosis factor agents. These medications include infliximab and adalimumab, which are often used in the treatment of inflammatory bowel disease. Research has consistently demonstrated that patients who generate antibodies against their initial anti-TNF therapy are at a higher risk of developing similar antibodies when switching to a second anti-TNF medication. This increased risk is independent of the order in which the medications are used, whether a patient begins with infliximab followed by adalimumab or vice versa. For example, a large multicenter study revealed that patients who first developed immune responses to adalimumab were significantly more likely to produce antibodies against infliximab upon switching, with 64% of such patients developing antibodies compared to 40% of those who had not previously developed antibodies against the first drug. Conversely, patients who initially developed antibodies to infliximab were more prone to produce antibodies to adalimumab after switching, with 34% doing so compared to 20% in patients without prior antibody development. Furthermore, the likelihood of developing antibodies to the second medication increases with higher concentrations of antibodies against the first. This dose-dependent relationship indicates that the greater the amount of anti-drug antibodies present against the initial therapy, the higher the odds of developing antibodies to the subsequent medication. The mechanism involved is predisposition rather than direct cross-reactivity between antibodies. This means that it is not typically the case that the same antibodies attack both drugs directly. Instead, the initial immune response acts to prime the patient's immune system. After the patient has mounted a response to the first biological treatment, they develop a predisposition to react to a second, structurally similar molecule within the same therapeutic class. This process establishes an immunological memory, which can lead to a faster and more potent formation of anti-drug antibodies upon subsequent exposure to a related biological medication. Class-specific priming refers to the phenomenon where the priming effect is confined primarily within the same class of biologic medications. For instance, if a patient has developed antibodies against anti-tumor necrosis factor agents, this history does not necessarily increase their risk of developing immune responses to biologics that operate through different mechanisms of action, such as vedolizumab or ustekinumab. This observation implies that the immune system's memory response is specific to the class of drug rather than to biologics in general. These examples underscore the clinical importance of a patient's treatment history. When a patient loses response to a biologic due to immunogenicity, their history of ADA formation becomes a critical risk factor to consider when selecting the next course of therapy, especially if the choice is another agent from the same drug class. The way a biologic medication is administered, including the dose, frequency, and route, can significantly influence the immune response, providing important opportunities to reduce associated risks. The dose and dosing schedule have a complex but essential impact on the development of immunogenicity. Interestingly, for some biologic drugs such as infliximab, there is an inverse relationship. Higher doses are linked to lower rates of anti-drug antibody formation. This counterintuitive phenomenon is likely due to high-dose tolerance, where sustained high concentrations of the drug overwhelm the immune system's capacity to respond. This situation promotes a state of tolerance and ensures that any anti-drug antibodies that do form are saturated by excess drug, preventing their detection and the expansion of B-cell clones responsible for producing these antibodies. The interval between doses is equally critical. Longer intervals have been associated with a higher incidence of anti-drug antibodies for certain respiratory biologic medications. This may occur because drug levels decrease sufficiently between doses to allow an immune response to develop. As a result, intermittent or interrupted therapy, often termed drug holidays, is a significant risk factor for breaking immune tolerance and triggering a potent immune response upon re-exposure. The route of administration is an important factor to consider, with ongoing debates regarding the relative risks of subcutaneous versus intravenous delivery methods. From an immunological perspective, the subcutaneous route presents a higher theoretical risk. This is because the subcutaneous tissue is rich in potent antigen-presenting cells, and administering a biological agent subcutaneously results in slower absorption and extended drainage through the lymphatic system. Such a process creates an environment where there is sustained, high local concentration exposure of the biologic to the key immune system sentinels. This mechanism is similar to how vaccines are administered to maximize immune response. However, despite this clear theoretical risk, clinical data from marketed products often reveal similar rates of immunogenicity between subcutaneous and intravenous formulations. This suggests that for many modern biologic drugs that are highly humanized and have low inherent immunogenicity, factors related to the product itself and the individual patient may play a more significant role than the route of administration. Finally, concomitant medications, particularly medications that suppress the immune system, are a powerful tool for reducing the immune response against biological therapies. The simultaneous use of drugs such as methotrexate or azathioprine with biologic agents, especially those that inhibit tumor necrosis factor, has been consistently shown to significantly decrease the frequency and strength of anti-drug antibody formation. These observations suggest the existence of a therapeutic Goldilocks zone for dosing, an optimal range that minimizes immunogenicity. A dosing strategy should be designed to maintain a consistent lowest concentration in the blood that is not only effective but also high enough to promote immune tolerance. This provides a strong rationale for the use of proactive therapeutic drug monitoring. For pharmacists, the goal of therapeutic drug monitoring should extend beyond simply maintaining efficacy. It should also actively prevent the immune system from developing antibodies by keeping drug levels within this tolerogenic window. Doing so can help preserve the long-term viability of the therapy for the patient. Effective management of immunogenicity requires a structured and proactive surveillance plan. This plan should include not only knowing when and how to test for anti-drug antibodies, but also how to integrate laboratory data with pharmacokinetic, pharmacodynamic, and clinical observations to guide patient care. To ensure the accuracy and reliability of immunogenicity assessments, regulatory agencies and industry experts recommend a multi-step or tiered testing strategy. This approach is designed to systematically identify and characterize anti-drug antibodies, balancing high sensitivity during initial screening with high specificity in subsequent confirmation steps. The process begins with a highly sensitive screening assay, such as an enzyme-linked immunosorbent assay or electrochemiluminescence-based method. The primary objective of this initial step is to identify all potentially positive samples while minimizing the risk of false negatives. To accomplish this, the cutoff point for the assay is statistically set to allow for a certain percentage of false positives, typically around 5% in clinical studies. Any sample that tests negative at this stage is considered negative and does not require further testing. The second tier of the testing process is the confirmatory assay. All samples that test positive in the initial screening are then subjected to this more specific test. The purpose of this tier is to accurately identify true positives and eliminate false positives from the screening step. The most common method used for confirmation involves a competition or immunodepletion step. In this process, the patient sample is pre-incubated with a high concentration of the therapeutic drug. If the antibodies present are specific to the drug, this pre-incubation will block them, resulting in a significant reduction in the assay signal when compared to an unspiked sample. A reduction in signal below a predefined threshold confirms the presence of drug-specific anti-drug antibodies. Tier 3 involves the characterization and titration of a sample. Once a sample is confirmed to be positive, it undergoes further detailed analysis. Titration is a semi-quantitative method used to estimate the magnitude of the antibody response. This process involves serially diluting the sample and identifying the highest dilution that still produces a positive result. This value is reported as the titer. In some cases, additional types of characterization, such as identifying the specific immunoglobulin class, whether IgG, IgM, or IgA, may be performed. These additional tests provide more insight into the nature and maturity of the immune response. The Tier 4 neutralizing antibody assay is a crucial functional test conducted on confirmed positive samples to determine whether the anti-drug antibodies can neutralize the biological activity of the drug. These neutralizing antibodies are often more directly associated with a loss of therapeutic effectiveness, making this information vital for clinical interpretation. The Food and Drug Administration generally prefers cell-based assays for measuring neutralizing antibodies. These assays evaluate the ability of anti-drug antibodies to inhibit the drug's effect on a cellular response, such as cell growth, cell death, or reporter gene activity. Because of this, cell-based assays can more accurately simulate the drug's mechanism of action within the body. However, such assays tend to be complex, expensive, and may vary in results. As practical alternatives, non-cell-based competitive ligand-binding assays are often used. These tests measure the ability of anti-drug antibodies to prevent the drug from binding to its target in a plate-based format. They are generally more feasible and cost-effective, providing valuable information in clinical settings. The choice of bioanalytical platform can significantly impact the results of immunogenicity testing. The two most common technologies are the enzyme-linked immunosorbent assay, ELISA, and electrochemiluminescence, ECL, immunoassays. The ELISA has long been the workhorse for ADA detection. The bridging ELISA format is particularly common and offers high specificity because it requires the bivalent ADA to form a bridge between a capture and a detection version of the drug. A major limitation of many ELISA formats, however, is their susceptibility to drug interference. High concentrations of the therapeutic drug circulating in the patient's sample can bind to the anti-drug antibodies, masking them from detection and leading to false negative results. The ECL platform, often associated with mesoscale discovery, MSD, represents a more modern approach that has gained wide adoption. ECL assays typically offer significant advantages over traditional ELISAs, including higher sensitivity, a broader dynamic range for signal detection, and, most importantly, superior drug tolerance. This enhanced drug tolerance allows for more reliable detection of anti-drug antibodies even in trough samples where substantial levels of the therapeutic may still be present, which is a critical advantage in a clinical setting. Pharmacists need to understand that immunogenicity results are highly assay-dependent. The observed incidence of anti-drug antibodies for a given drug can vary dramatically across different studies or clinical laboratories due to differences in assay format, ELISA versus ECL, sensitivity, drug tolerance, reagents, and statistical methods for cut point determination. Therefore, ADA rates from a package insert cannot be directly compared to a result from a local hospital laboratory. Proper interpretation requires an understanding of the specific assay's performance characteristics and limitations, a factor that poses a significant challenge when insurance providers mandate changes in laboratory services. Immunogenicity testing should not be performed in a vacuum. Its clinical value is fully realized only when integrated with pharmacokinetic, PK, and pharmacodynamic, PD, monitoring. A change in drug concentration, PK, is often the earliest and most sensitive indicator of a clinically meaningful immunogenic response. The formation of clearing anti-drug antibodies can cause a significant drop in trough drug levels, and this reduction in exposure often precedes any observable decline in clinical efficacy. Therefore, monitoring drug concentrations alongside ADA status provides a more complete picture. The practice of therapeutic drug monitoring, TDM, has become a cornerstone of managing biologic therapies, particularly in fields like gastroenterology. TDM can be employed reactively, testing in response to a loss of efficacy, or proactively, with routine testing to maintain drug levels within an established therapeutic window. The data increasingly support a role for proactive TDM, not just as a tool for efficacy optimization, but as a strategy for immunogenicity mitigation. Since low trough drug concentrations are a risk factor for ADA development and higher, sustained drug levels appear to promote immune tolerance. Using proactive TDM to keep drug concentrations consistently within a target range may actively suppress the formation of an immune response. This shifts the pharmacist's role from simply reacting to low drug levels to actively managing them to preserve the long-term viability of the therapy. A positive ADA test result requires careful interpretation within the patient's full clinical context. An ADA response is only considered clinically significant if it is demonstrated to have a negative impact on the drug's PK, PD, efficacy, or safety. A low-titer, transient ADA response that does not affect drug levels or clinical outcomes is of little concern. In contrast, a high-titer, persistent, and neutralizing ADA response that is correlated with falling drug levels and a loss of efficacy is a clear signal for clinical intervention. In addition to laboratory monitoring, pharmacists must remain vigilant for the clinical signs and symptoms of immune-mediated adverse reactions. This includes monitoring for immediate hypersensitivity or infusion reactions during and after administration, characterized by symptoms like rash, urticaria, dyspnea, or hypotension. For certain classes of biologics, such as immune checkpoint inhibitors, monitoring must be broader, including baseline and periodic laboratory tests to screen for organ-specific immune-mediated toxicities like pneumonitis, colitis, hepatitis, and endocrinopathies. Patient education on recognizing and reporting these symptoms promptly is a critical pharmacist-led intervention. To illustrate the integration of these monitoring principles, consider the following case. A 35-year-old male has recently been diagnosed with moderate to severe Crohn's disease. He was started on infliximab therapy as his sole medication, following a standard dosing schedule. After the initial induction phase, he achieved clinical remission and responded well to the treatment during the first 9 months of therapy. During the patient's 10-month follow-up visit, he reported a gradual return of symptoms. These symptoms included increased stool frequency and abdominal pain, which are consistent with a secondary loss of response to the treatment. The clinical team, including a pharmacist, decided to implement reactive therapeutic drug monitoring to investigate the cause of these recurring symptoms. To do this, a blood sample was collected immediately before his next scheduled infusion. This sample was used to measure the levels of the drug in the blood, specifically the trough drug level, as well as the levels of anti-drug antibodies, which could indicate an immune response against the medication. Laboratory results indicate that the infliximab trough concentration is less than 1.0 micrograms per milliliter, which is significantly below the established therapeutic target. This low drug level serves as a sensitive early indicator of a potential immune response against the medication or other pharmacokinetic issues. Immunogenicity testing was conducted using a tiered approach. The first 2 tiers involved screening and confirmation through an electrochemiluminescence assay, which was selected for its high sensitivity and ability to tolerate the presence of the drug. The assay returned a positive result for antibodies against infliximab, which was subsequently confirmed. In the third tier, the confirmed positive sample was titrated, revealing a high antibody titer and indicating a strong immune response. In the final tier, a cell-based neutralizing antibody assay was performed, which also yielded a positive result, suggesting the presence of antibodies capable of neutralizing the drug's effect. The clinical pharmacist reviewed the patient's condition, noting a deterioration in health characterized by a loss of response to treatment. This decline was directly linked to a drug concentration that was below the therapeutic level, indicating a pharmacokinetic effect. Additionally, the presence of high-titer, neutralizing anti-drug antibodies, which is a sign of immunogenicity, was identified. This combination confirms a classic case of treatment failure driven by immunogenic responses. The neutralizing antibodies are likely causing the body to clear the medication more rapidly and are also directly blocking the activity of any remaining drug, which renders the therapy ineffective. Based on this comprehensive assessment, the team concludes that simply increasing the dose or frequency of infliximab would be futile and not cost-effective, as the high level of NAbs would likely neutralize the additional drug. The definitive management is to discontinue infliximab and switch to a new biologic. Given that a history of immunogenicity to one anti-TNF agent increases the risk of developing anti-drug antibodies to a second anti-TNF, the team opts to switch to a drug from a different class, such as an anti-integrin, vedolizumab, or an anti-interleukin, ustekinumab, to avoid this class-specific priming effect. The patient is educated on the new therapy, and a plan for ongoing clinical and laboratory monitoring is established. The culmination of risk assessment and clinical surveillance is the implementation of targeted therapeutic strategies to prevent or manage immunogenicity. This requires a proactive approach for high-risk patients and a clear, evidence-based algorithm for responding to treatment failure or adverse reactions. Tailoring therapy for high-risk patients begins with early identification of individuals who are more likely to develop a significant immune response. Healthcare providers can utilize a comprehensive, multifaceted approach to evaluate these patients. This approach involves assessing the patient's genetic profile, such as their human leukocyte antigen type, reviewing their medical history for previous development of anti-drug antibodies when treated with other biologic medicines, and understanding the nature of their underlying disease. By carefully considering these factors, clinicians can better stratify patients according to their risk levels and develop personalized treatment strategies. For patients identified as being at high risk, it is advisable to consider several proactive strategies at the beginning of treatment. One such strategy is the concurrent use of immunosuppressive medication. In cases where there is supporting evidence, such as the use of methotrexate alongside anti-tumor necrosis factor agents in the treatment of rheumatoid arthritis, it is strongly recommended to administer this combination therapy. The purpose of this approach is to prevent the formation of anti-drug antibodies by suppressing immune responses proactively. Selecting an alternative biologic can sometimes be the most prudent strategy. In certain cases, avoiding the high-risk agent altogether is advisable. For example, in a patient with inflammatory bowel disease who is known to carry the HLA-DQA1*05 genetic marker, choosing a biologic from a different class may be preferable. Instead of an anti-tumor necrosis factor agent, an anti-integrin or anti-interleukin agent might serve as the optimal first-line treatment. This approach can help prevent treatment failure caused by immunogenicity. In rare and critical situations, it may be necessary to implement specialized immune tolerance induction protocols. These situations typically involve administering a life-saving protein to a patient who is genetically predisposed to a strong immune response. For example, in enzyme replacement therapy for patients with complete gene deletions, careful management is required to prevent adverse immune reactions. Infusion reactions are a common manifestation of an immune response to a biologic. Premedication with antihistamines, H1 and H2 blockers, corticosteroids, and/or antipyretics is a widespread practice aimed at preventing or lessening the severity of infusion reactions. However, the evidence supporting routine premedication is inconsistent. While some studies have shown a benefit for specific drug-patient combinations, such as dexamethasone with trastuzumab, others have found no significant reduction in reaction rates, particularly for infliximab in IBD patients, calling into question the utility of routine premedication in low-risk scenarios. If an acute reaction occurs, the standard procedure is to immediately stop the infusion, assess the patient's vital signs, and provide supportive care, which may include administering emergency medications. Once symptoms resolve, the infusion can often be cautiously restarted at a slower rate. For patients with confirmed, severe hypersensitivity reactions who have no alternative therapeutic options, rapid drug desensitization is a specialized procedure to induce a state of temporary tolerance. This is performed in a highly controlled medical setting and involves administering the culprit drug in incrementally increasing doses over several hours, starting with a minute fraction of the therapeutic dose. The mechanism is thought to involve the controlled, gradual engagement of mast cell and basophil receptors, which prevents the massive, coordinated degranulation that causes anaphylaxis. Standardized protocols, such as the 12-step, 3-bag method, have proven to be safe and highly effective, allowing the vast majority of patients to receive their full, necessary therapeutic dose with only mild or no breakthrough reactions. The 12-step, 3-bag method is a widely accepted, standardized protocol for rapid drug desensitization, RDD, developed at Brigham and Women's Hospital. It is designed to safely reintroduce an essential medication in patients with a history of immediate hypersensitivity reactions when no suitable alternative exists. The procedure induces a temporary state of drug tolerance, allowing the patient to receive the full therapeutic dose over a period of approximately 6 hours. The core principle of the protocol is the administration of gradually increasing doses of the drug at fixed 15-minute intervals, starting with a dose low enough to be below the threshold for mast cell and basophil activation. This incremental exposure renders these key effector cells hyporesponsive, preventing the systemic degranulation that leads to anaphylaxis. The protocol is structured as follows. Preparation of solutions. 3 separate intravenous bags are prepared from the total target dose of the drug. These bags contain serial dilutions of the final therapeutic concentration. Bag 1. A 1 to 100 dilution of the target concentration. Bag 2. A 1 to 10 dilution of the target concentration. Bag 3. The full, undiluted target concentration. Administration protocol. The desensitization is carried out in 12 distinct steps, with the infusion rate typically doubling at each 15-minute interval. Steps 1 to 4 are administered from bag 1. Steps 5 to 8 are administered from bag 2. Steps 9 to 12 are administered from bag 3, with the final step continuing until the full therapeutic dose has been delivered. Premedication and monitoring. Patients are typically premedicated with corticosteroids and H1/H2 antihistamines prior to starting the protocol. Throughout the procedure, which takes place in a medically supervised setting, the patient is closely monitored for any signs of a breakthrough reaction. This standardized method has been proven to be both safe and effective across a range of biologics and chemotherapeutic agents, with success rates exceeding 99% in some studies. While breakthrough reactions can occur in a minority of cases, they are typically mild and manageable. It is critical to recognize that the tolerance induced by RDD is temporary. If treatment is interrupted for more than 2 drug half-lives, the patient's hypersensitivity is likely to return, necessitating a repeat of the full desensitization protocol for subsequent doses. When a patient experiences treatment failure, immunogenicity testing and TDM provide the necessary data to guide the next therapeutic step, moving beyond empiricism to an evidence-based decision. A unified algorithm can be constructed to manage these complex clinical scenarios. The initial step when a patient stops responding to a medication is to measure the lowest drug concentration in the blood, known as the trough level. In a scenario where the drug level is within the therapeutic range but the patient does not show clinical improvement, the issue is not related to how the body processes the drug, but rather how the drug affects the body. This indicates that the disease pathway no longer responds to the drug's mechanism of action. In such cases, increasing the dose or switching to another medication within the same class will not be effective. The appropriate course of action is to switch to a biological therapy that works through a different mechanism of action. If the concentration of the drug in the trough is low, it indicates that the failure is due to pharmacokinetic reasons. The next step is to measure the levels of anti-drug antibodies. In a different scenario, where there is a low drug level but no or low levels of anti-drug antibodies, this suggests a non-immunogenic cause of rapid drug clearance. Such causes could include increased metabolic demand or simply underdosing. To address this issue, it is appropriate to increase the dose or shorten the interval between doses to improve the therapeutic outcome. In the scenario characterized by low drug levels combined with high levels of anti-drug antibodies, this situation typically indicates immunogenicity-driven treatment failure. The elevated levels of anti-drug antibodies are responsible for accelerating the clearance of the drug from the body or neutralizing its effect. Increasing the dosage of the current medication is unlikely to be successful and may not be a cost-effective approach, as the immune response will likely eliminate the additional drug. The most effective solution in this case is to switch to a different biologic agent. The choice of the next medication may involve selecting another drug within the same class or opting for a drug from a different class, depending on the specific clinical situation and the patient's medical history. This structured, data-driven approach helps clarify the management of treatment failure in clinical practice. It provides healthcare professionals with a straightforward and logical pathway to identify the root cause of therapy failure. Causes may include mechanistic issues, non-immunogenic pharmacokinetic factors, or immunogenic pharmacokinetic factors. Once the underlying cause is determined, clinicians can select the most appropriate and cost-effective subsequent therapy. Implementing such an algorithm within a clinical setting is a crucial role for pharmacists. It ensures the optimal use of these powerful yet expensive therapies, contributing to better patient outcomes and more efficient healthcare delivery. Immunogenicity is a complex, multifactorial phenomenon that represents a significant challenge in the clinical use of biologic therapies. It is not a binary event, but a spectrum of immune responses with consequences ranging from clinically silent to life-threatening. The most frequent and fundamental impact of immunogenicity is the alteration of drug pharmacokinetics, leading to accelerated clearance and reduced exposure, which in turn often results in a secondary loss of therapeutic efficacy. The clinical pharmacist is uniquely positioned to play a pivotal role in the management of immunogenicity. This role extends beyond dispensing to encompass a deep, mechanistic understanding of the product-related, patient-specific, and treatment-related factors that contribute to immunogenic risk. By leveraging this knowledge, pharmacists can identify high-risk patients and advocate for proactive mitigation strategies, such as the use of concomitant immunomodulators or the selection of alternative first-line therapies. Furthermore, pharmacists are essential for guiding the rational use of therapeutic drug monitoring and immunogenicity testing. A key responsibility is to educate fellow healthcare providers on the nuances of these assays, including their limitations and the non-interchangeability of results, and to champion a structured, algorithmic approach to interpreting the data. By integrating laboratory results, ADA status, NAB activity, and drug concentration, with clinical observations, pharmacists can help delineate the underlying cause of treatment failure and guide evidence-based decisions, whether that involves dose intensification, switching to a new agent within the same class, or selecting a therapy with a novel mechanism of action. Through patient counseling on adherence, proper drug handling, and the signs of adverse reactions, and through collaborative practice with prescribers to implement proactive monitoring and management plans, the clinical pharmacist can significantly enhance the safety, efficacy, and long-term viability of biologic therapies for every patient. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.